Welcome to the AI Shift, a show looking at the seismic changes happening in healthcare with artificial intelligence at the epicenter. I'm your host, Tom Foley. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and for the future. And now, the AI Shift. Welcome. This is Tom Foley, and you're listening to the AI Shift. This is a great opportunity today. We have Tom Leary, who is the Senior Vice President of Government Relations at HIMSS. Tom, welcome to the program.
Great to be with you again, Tom.
Awesome. Yes, great to have you back. It's a week of anticipation, and HIMSS is coming up. HIMSS26 is coming up. It's in Vegas. Can't wait to be there and re-engage. I actually think this is going to be my 20th year going to HIMSS.
Wow.
So I'm really excited about going back. It's one of those shows that you got to be at, in my view. It's the networking mecca of the healthcare community, in my view. So I'm glad to have you on the program, because there's a lot of important things going on from a government relations perspective, and more so on as it relates to AI. I'm sure it's going to be a hot topic at HIMSS. So why don't we just start off? Tell us a little bit about what you do at HIMSS from government relations, and we'll get into the discussion.
Sure, absolutely. And hello again, everybody. And it's HIMSS26 is going to be very exciting from a government relations perspective, both U.S.-based and globally. We anticipate a good number of countries coming to talk about AI and an assortment of other topics, but AI being front of mind for most everyone. What we're very excited about is that we're expecting a good number of people from CMS returning. As you can imagine, from the last few years, it's been CMS represented by just a few people, but we're excited that Dr. Oz and his team will be there as part of the keynote on Thursday, as well as Amy Gleason and Kim and a whole host of individuals talking about a wide range of topics, everything from waste, fraud, and abuse to clinical quality measures. But the important underlying theme is how to better leverage AI and machine learning into improving how CMS delivers for the patient and for the provider. So they're going to be there. We're expecting a pretty good sized contingent from the Department of Veterans Affairs, not just the Veterans Health Administration, but VA's new Chief Financial Officer, Mr. Topper, will be there talking about a new IDIQ and a new approach to how they're anticipating leveraging technology and a new contracting approach for their managed care support contracts. So looking forward to that. Looking forward to some great presentations out of the VA. Then DoD will have several very high level conversations around where they're headed with respect to technology and AI. And then I think the last one from a federal government perspective is the Office of Civil Rights. The head of the Office of Civil Rights will be there talking about not only the anticipation of a security rule update, but more importantly, from her perspective, the Trump administration's viewpoint on how privacy and security can be advanced in an AI-enabled world. From a state level, we have over 25 states going to be represented, through their state health officers and other senior officials, and then even the local perspective here from the U.S. with Councilwoman from Baltimore, who has a background from CMS. Then she ran for office in Baltimore. Felicia is going to be with us talking about AI-enabled education, or AI education and enabling a diverse workforce for the health IT community. So from a US and from local all the way up to federal, very well represented, and lots of focus on artificial intelligence. Of course, we can get into some other conversation around what's happening from a global perspective, with whether it's Singapore or Korea or any of the other countries that will be there at conference.
Well, that actually sounds like a very busy, information-packed conference for sure, as it always is at HIMSS. You guys do a great job in prepping the audience and delivering on the expectations once they get there. Obviously, HIMSS, AI has been the hot topic, and you have a very broad membership base, health systems, independent doctors, things of that nature. What are you hearing from them in terms of what they're looking for support on in the context of how do I navigate this thing called AI?
That's what they're looking for from a policy perspective. And we've been talking to them for, we had policy principles as far back as 2018 on AI and machine learning. But with the acceleration of AI use in healthcare starting in 2023, we've updated the AI principles and even updating them in the fall of 2024, we're reminded on a pretty frequent basis, hey, you forgot this. Hey, and what this is just underscoring the idea of responsible use of artificial intelligence in healthcare. What does that mean? What are the guardrails? How does government help create guardrails that allow for innovation, but also reminds us that healthcare is not exactly the same as other sectors because you're dealing with a patient, not to be so dramatic as to say a patient's life, but it's making sure that the information that's being presented and being collected and then having AI utilized, it still comes down to make decisions, the clinician, the patient, and the caregiver working together to make decisions on behalf of the patient. And those are healthcare, the body of the individual related. So making sure that it's responsible use as well as the accuracy of the information are really important for everyone. Where we're having some debate amongst the membership is where can it be used, and where does there have to be an individual, a clinician involved in the decision making. So, as if you think about even clinical decision support conversation dating back a decade or more here in the US, where we've had a dialogue with the FDA and others, is at what point does the information that's available inform, say, a piece of medical equipment, and then the medical equipment uses that information to make an adjustment to the patient's care without a clinician involved. That's where we've consistently have had the red flags of the final decision to make those adjustments to the medical device has to have a clinician involved. But as we get more and more advanced AI, and what we heard just recently at the ASTP, the Assistant Secretary for Technology Policy and ONC, their meeting just 2 weeks ago, there was conversation where ARPA-H, the new advanced research agency for healthcare that's been in place since 2022, 2023, they're starting to explore what does it mean to actually not need a human in the loop. Advanced technologies that don't need, it relies so much on such rich data that the adjustment to the pump or other medical device can happen without a human. So yes, it's on the horizon, and the horizon's getting closer, but that's really one of the big topics. The other big topic from a policy perspective is the federal government and the executive order that's come out from the president in the last few months, stating that putting a pause on state level AI guardrails to allow for time for a federal plan, one, and two, to not put too tight a guardrails on an individual state basis. So you'd have potentially 50 states plus the 6 territories having some commonality, but some very unique guardrails that would slow down innovation. So there's debate going on amongst our membership, and quite frankly, between the federal government and the states, as to whether or not the federal preemption by executive order is something that that is going to pause California or Arkansas or any of the other states that are really leaning in on AI and healthcare, if that's going to limit the guardrails. So it's the innovation and federalism, federal versus state policy direction. What we've been saying for the last couple of years, and I think is important for the conversation at HIMSS 26, is that the membership has been saying to us, we need a federal direction, but really what we need is legislation and coming out of Congress that defines the what the path forward looks like. Because if we don't, then we're going to have regulation by default that comes from, say, Europe with their AI Act that was passed 2 years ago and has gone into effect just in the last few months. If the multinational corporations want to build towards something, and they'll build towards the AI Act and the framework that's been developed in Europe, in the European Union, if the US doesn't have its own framework or doesn't have a complementary framework. So really what we've been pushing for is legislative action at the congressional level that can withstand a change in administration and really provide a roadmap for moving forward and continuing that innovation and protection of the patient at the same time.
Unfortunately, I have been involved in health IT back when there was no certification of an EHR, right? And I relate this somehow in some way to that, in that there were several EHR vendors. And they all did different things, right? And that was part of the problem, is that you had one label EHR, EMR at the time, but they all did different things. So CC HIT came along and said, hey, this is the definition of an EMR. If you want to get certified on that, go for it. And I'm happy to say I was one of the first 13 to do that. But then the federal government came along in the HITECH Act and said, thou shalt adopt, right? And there were still some challenges with the structure of an EHR, the quality of the data, things of that nature, but things were moving off of that piece of paper into an electronic system. What I want to call out in that is that the government did not lay a hand, if you will, on letting the market mature.
Right.
EHRs were out there. They did what they did. The market drove it to 2009 when finally the HITECH Act came out and the federal government came in and started defining standards. So I'm a believer that that's what we need to do now. To some degree, we have to keep our hands off, if you will. We're all perfectly aligned in the idea that for privacy and security, I totally understand why that is so important. And you're right, earlier, in healthcare, it's different. You have to get it right. Because I do believe, and I will go as far as say, hey, somebody's life is on the line, right? And even in today's world, in the EHR world, we have a lot of medical errors, part of the problem that are coming out, or have been ever since the EHR was there. Mm-hmm. Medical errors that do lead to death, they're well documented. So it's not, I sometimes sense that AI is viewed as trying to be positioned as a perfect system when we already are working from an imperfect world, right?
Right.
And so I think that there's still a lot to do. And I think, as you know, may not know, actually, I now work for Doctronic. I'm not promoting, but the point, and this is not a sponsorship for them, but AI is here and it does operate autonomously today, at least in the state of Utah. But the point is that I think we should look at AI and find use cases. One of the things I used to promote I still promote it on my program, is that the overall fundamental problem is that for a Medicare patient who has 5 chronic conditions, they have 9 different doctors on their care team. They only spend 15 hours in a given year in front of those doctors.
Right.
The question in healthcare is what happens the other 8,745 hours? Mm-hmm. That's where wellness occurs.
Right.
And I equate that to a very large health system that I'm speaking with, And their business problem is the exact same. I have less doctors and nurses available to me, but I have a very large population that is scaling in terms of number of chronic conditions. They're sicker.
Right.
I can't scale. That's their business problem. I have less doctors and nurses, and I got more and more sicker patients. You're not going to fix that problem by throwing people at them because you don't have them.
Don't have the people. Right. No, and that's not just a U.S. issue. It's a universal.
That's a global issue.
Yeah.
Yeah. So the question is that, so there's some belief that this is where AI is of value, in the idea that I can use AI. We use AI in healthcare today. We use it for claims management. We use it for ambient listening. We use it in a number of different use cases, but not so much directly into the heart of the matter of how do we make healthcare better through the use of AI.
Well, and that's what we're starting to see with different projects that are underway, whether it's government funded or individually, just health systems recognizing they've got a people problem, and they've got technology that can help solve some of the people problem. There's the chairman of the Senate Health Committee down in South Carolina is talking about, they've got one OBGYN for 5 counties. And so how do you solve that? If you've got a federal program that incentivizes someone coming in and they get a higher pay, and then you've got a state program that supplements that because the federal program isn't a high enough salary, but neither of those are attracting people. How do you address it perhaps with technology to help to make some of the decision making easier? And that's the other part of AI that we're starting to see is, it's the ambient listening, it's all the things that make the administrative work simpler, but also how do you make it so that remote patient monitoring perhaps is more is aided by AI. Al Wolf, our CEO, talks a lot about how when he was with Kaiser, they were using AI, as part of remote patient monitoring to make sure that if a patient stays within this range, everything's good. If they go to the left of the range or to the right of the range, there's something is alerted and provider is able to jump into action. But you don't need someone necessarily checking all the time if someone's in range. And so that's where AI tools can be very helpful. Well, we're also seeing, our Office of Scientific Research has been really pushing forward the idea of something that perhaps you and I have seen before, but there's more and more documented evidence of the use of technology helps with your quality scores, and then the outcomes that individuals and health systems are seeing. It's how do you then leverage the best of the best that's happening across the country or across the globe for how do you leverage some of those best practices in a way that, and then use the technology to augment the provider work or to be inclusive so that if there isn't a provider, you can use some of these use cases or these best practices to bring the better outcomes to every community.
Yeah. So to your point, rural health is a perfect example, right? You don't necessarily have doctors, patient, or let me just say it differently. You have patients that have to travel an hour, 2 hours just to get to a doctor's appointment. And that doctor's appointment is only 10, 15 minutes at best. And then they got another 2-hour drive home. This is where technology, AI, can be a great facilitator in that it's not making a clinical decision, but it's at least helping collect the information, so that it can be presented. To your point, the doctor's still in the middle, but if I can collect the information in advance of a clinical encounter that ultimately facilitates the doctor making that decision, it would be better, right? I speak to doctors all the time. I always say, they didn't go to medical school to be a typist. They didn't go to medical school to be a data entry clerk in an EHR system, right? So, but that's what they do, right? They're asked to type, listen and talk all at the same time.
Mm-hmm.
And in that very short window of a 13-minute encounter, right? But if I can educate that provider through the use of AI because I collected all the clinical information in advance, that seems to me like we can then see more patients because I don't have enough skilled doctors available. It's how do we
Right.
make the
Right.
doctor more efficient, right?
Yeah,
But yet,
absolutely.
and to your point, I'm not making any clinical decisions, but healthcare is a 24/7 operation in the context of I'm living, and but I can't rely on just seeing the doctor in that 15 minutes
Yeah. If you
of time. So to your
exactly.
point of remote monitoring, if I was feeding like remote monitoring today, you have to have a certified device. He's got to send the information automatically. There's no patient entry of data. But if AI were to get that data, it would say, hey, keep up the good work. I don't need a human in the middle. I have a
Right.
doctor in the middle. I have a doctor in the middle. Don't get me wrong. And that doctor is human, by the way, but I don't need all the. I think what AI tries to do is it's not eliminating anybody's job in healthcare. That's not the intent, and that's not what's going to happen because we're so short anyway.
Right. Right.
Right. So
But yeah.
so I'm just it's just a matter of how do I create efficiency because the one thing the patient doesn't have is day-to-day guidance. Where's that coach, if you will,
Yes.
with
Yeah.
the build out of the AI and what it can do? Where's that coach that can coach me? Hey, did you take your meds today? Did you take your blood pressure today? Did you walk? Did you get your 2,000 steps in?
Steps in. Right.
It's
Right.
it's that
Yeah.
daily reminder of
Yeah.
hey, again, it's a coach oriented approach versus pounding on them about what they should and shouldn't do type of thing.
So along that line, then, in part of what policy has to take into account is what I'm hearing from some CMOs is that now that you've got an engaged patient and I've got technology that's reminding them to get their steps in and take their medicines and on time, and the individual is seeing better outcomes that maybe translate towards a decrease in their medication or a change in their medication. And
That's right.
so what's happened in one it wasn't a health system, but it was one of the EHR CMOs was saying the challenge we've got now is we've got a more informed patient who's saying, all right, doc, sending a note in, hey, all right, doc, I need, numbers are this for the last 90 days, like you said, I need to change my medicine. And then the doctor is overwhelmed by empowered patients and doesn't have the time to send, to make the changes or to send a note to make the change. So instead, the person calls 3 or 4 times and finally the doctor says, just have them make an appointment and I can have the conversation with them. So all of a sudden all the technology that could have made things more efficient for them, they're being overwhelmed. So it's not just fewer providers, it's the amount of data that's coming in. And the final piece it's really going to be debated, I think, at Global Conference is the idea that's coming out of ASTP ONC in that information blocking can be also being redefined to you have to respond to any human or any AI or any chatbot or whatever that might have come from on it's inquiring on behalf of the patient, because the patient by the law, by the 21st Century Cures Act, has access to their data under any means available to them. So if you've got, we've had some estimates of, and I'm still trying to wrap my head around this, but the idea of 4 million requests coming in to one health system, how do you respond to that in such a timely manner that you're not seen as information blocking? So everyone's empowered to get the data and everyone's empowered to respond to the data, but we don't have the individual, the people or the processes in place enough to be able to handle that volume. So it's the policy discussion on the benefits of AI, and then it's the benefits, it's the process changes that need to occur, And then, of course, the concerns around, hey, you've gone too far, you've impacted my privacy, or the tool has made a decision on a person's behalf, and they're hurt. All those. That's the whole spectrum of conversation that's happening around AI in healthcare.
Well, I had to stop you there. I apologize, but we're
at time already.
Unfortunately, we should do a part 2, by the way. But I absolutely agree with you, because I work with the QHIMSS all the time, and access to the data is paramount. And I think that even TEFCA regulations need to be enhanced a bit, because I think there's, even though it's new, it's still running behind the times in the context of AIS use cases and treatment use cases, and getting that true access to the data to help benefit outcomes. But Tom, I truly appreciate you coming on the program again. It's great to see you, and I look forward to seeing you at HIMSS, which seems to be like a great show in the making. So I appreciate
you.
Stay
the whole time, everybody, because because Dr. Oz is speaking Thursday morning.
Thursday morning. Awesome. Tom, thanks again. I appreciate it.
Thanks, Tom. See you.
Take care. Thanks for listening. If you missed any part of today's episode, you can tune in at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. Be sure to check out the program page on healthcarenowradio.com, and remember to connect or follow me on LinkedIn, X, formerly Twitter, @FoleyTom, and follow the show's hashtag, The AI Shift. I'm Tom Foley. Until the next shift.